You know, when we talk about detective work, I think most of us, we picture a crime scene.
Yellow tape, fingerprints.
Exactly. Maybe a magnifying glass, right?
Yeah.
But today, the crime scene, it's a human body. And the main clue, the smoking gun, really is something so common, I bet almost everyone listening has just ignored it at some point.
A lump in the neck.
That's it. Just a little bump under your jaw. You think, oh, I'm fighting off a cold, or, I slept funny.
Just move on.
You move on.
Yeah.
But in the stack of documents we're looking at today, which is this really amazing mix of raw clinical notes, surgical guides, and a pretty harsh critique of a medical exam, that lump isn't just a bump, it's a coordinate on a map.
It really is. And if you don't know how to read that map, you're gonna get lost very, very quickly. We're looking at a case today that just perfectly illustrates the difference between, let's say, seeing a symptom and actually observing the system behind it.
Right.
We're gonna deconstruct the case of a patient we're calling Imran.
And what really stood out to me in these sources wasn't just the medical diagnosis, which, spoiler alert, is a wild ride, it's the critique. We have these notes where a senior surgeon is just, he's tearing apart a junior doctor's approach. It's like a masterclass in strategy.
It's brutal, but it's absolutely necessary because in this specific part of the body, the neck mistakes are, well, they're expensive. You miss one question, you skip one specific check, and suddenly you're treating a patient for a toothache when they actually have a life-threatening systemic disease.
So let's open the file. Tell us about Imran.
So based on the history here, Imran is a 30-year-old hotel worker from Umarkot, Sindh. He walks into the clinic with a chief complaint that's been brewing for a while. 3 months.
3 months is a long time to wait.
It is. His complaint is multiple swellings in the neck. And the way these swellings behaved is really our first big clue.
Okay.
It started as one lump, but then it multiplied. The notes describe them as discrete, like little separate marbles under the skin, but then they started matting together.
Matting, like hair.
Exactly like that, sticking together in a clump. And this is important, they're mobile. You can sort of wiggle them around and non-tender, they don't hurt.
And that's the trap, isn't it? Pain gets our attention. If it hurts, we go to the doctor right away. If it's painless, we think, oh, it's fine.
Precisely. And in the world of neck lumps, painless is often much, much more dangerous than painful. Pain usually means an acute infection, a war your body is actively fighting.
Right.
Painless often means something chronic, something growing.
But Imran didn't just have lumps. He had what the sources kept calling B symptoms. I saw that term over and over. What are B symptoms?
It's a kind of medical shorthand. It's for a specific triad of systemic red flags. If you see a lump and you hear these 3 things, your alarm bell should be going off.
Okay, what are they?
First, Imran has an intermittent low-grade fever. It's been coming and going for 3, maybe 4 months.
A fever, okay. That's pretty generic though.
It is, but you combine it with number 2,
Yeah.
night sweats.
And the transcript actually quotes him here. He says, pasina hota high, specifically at night, drenching sweat.
Right, and we aren't talking about being a little warm. We are talking about waking up, soaking wet, needing to change your clothes, change the sheets. That's a very specific signal.
And the third one?
Significant unintentional weight loss.
The notes say his clothes have become loose. He's shrinking.
Exactly. He's not on a diet. His body is just losing mass. So think about the picture we have now. A 30-year-old guy wasting away, sweating through his sheets at night, with painless lumps multiplying in his neck.
To me, that sounds terrifyingly like lymphoma, like cancer.
It definitely sounds like cancer, and it absolutely could be. But this is where the detective work has to pivot to his social history. You have to look at the context of his life.
Right, so his habits. He smokes 8 to 10 cigarettes a day for 15 years.
Which is a massive risk factor for head and neck cancer. So that cancer theory is still very strong.
He also drinks unboiled tap water, which, depending on where you live, introduces a whole bunch of other suspects. But there was one detail in the family history that felt like the moment the music stops in a movie.
The brother.
The brother is the key.
Yes.
Imran's brother had tuberculosis, and Imran lived with him while he was sick.
And not just that, the notes mention the brother's son also has neck lumps. Gallion, as the patient calls them.
And this is where that critique of the junior doctor comes in, right? Because the source points out this huge strategic failure.
It was a failure of sequence. The doctor didn't ask about the TB contact until the very end of the interview. It was almost an afterthought.
But why does the order matter so much? He got the information eventually.
Because it changes your cognitive filter.
Yeah.
Your brain is constantly calculating probabilities. If you know right from the start that he's a close contact of a TB patient, your whole index of suspicion shifts immediately. You stop looking for a tooth infection. You stop focusing only on cancer.
It's like if you know you lost your keys in the kitchen, you don't start by searching the basement. You go straight to the kitchen. Exactly. Which brings us to the anatomy of the investigation. This is where the sources get really technical about drainage basins. But it's actually a beautiful piece of logic.
I love this part. It's the plumbing logic of the body.
It's exactly like plumbing. Lymph nodes are filters. They catch bad stuff, bacteria, cancer cells that are draining from specific upstream areas. So if you know which drain is clogged, you know which room in the house the leak is in.
So let's map Imran's lumps. Where were they?
Okay, this is the nuance that makes or breaks the whole case. He had a large mass in the submandibular region. That's level I, right under the jawline.
Level 1. Got it.
But, and this is critical, he also had small nodes in the upper deep cervical chain. That is level 2. It's a bit further back and down.
Why is that distinction so important? Level I and level 2, they're right next to each other because of what they drain. Level I drains the mouth, the teeth, the face, the salivary glands. If you only see a lump there, you think, oh, maybe a bad tooth, a local problem.
Makes sense.
But level 2 is the drain for the nasopharynx, the oropharynx, and the larynx.
Nose in the throat?
Correct, the very back of the nose and the voice box. The source material just hammers this point home. Any node in level 2 changes the game. It means the problem might be much deeper.
So that second smaller lump means you can't just look at his teeth.
You are obligated to look deeper. The source material calls this ruling out an occult primary malignancy.
Occult as in hidden.
Hidden, yes. There are cancers. Nasopharyngeal carcinoma is the classic one, that are silent assassins. They grow in the back of the nose with 0 symptoms. The only sign they exist is a metastasis to a level 2 lymph node.
Wow, that's terrifying. So the cancer's in his nose, but the lump in his neck is the only thing you can see.
Exactly. And that's why the critique insists. If you find a level 2 node, you have to look up the nose and down the throat.
The notes listed some procedures for this. Anterior and posterior rhinoscopy.
They sound intense, but they're standard skills. Anterior rhinoscopy is just looking in the front of the nose, but posterior rhinoscopy, that's the art. Use a little angled mirror, go in through the mouth, and try to look up behind the palate.
And indirect laryngoscopy.
Same idea, but looking down. You hold the patient's tongue, put a mirror against their uvula, ask them to say E, and you're looking right at the vocal cords.
It seems like such a leap. You walk in with a lump on your jaw, and now there are mirrors down your throat. But logically, it connects perfectly.
It connects because of the drainage, you have to follow the plumbing. If you skip the mirrors, you're just guessing.
Speaking of doing things right, I love this section on professional authenticity. It's basically how to sound like you know what you're doing. But it's more than just fancy words, isn't it?
It is. It's about precision of thought. The critique says that using lay terms can make your thinking fuzzy. Like a patient says weight loss. A doctor should be thinking in terms of cachexia.
Cachexia. It just sounds more serious.
It implies a specific mechanism. It's not just I lost a few pounds, it's my body is consuming itself. Same with lymphadenopathy for lumps. These words carry diagnostic weight.
I also noticed a bit on bridging phrases. The idea that you say, I'm going to examine your neck now.
It sounds so trivial, right? But it's a clinical tactic. If a patient is nervous and you just lunge at their neck, what happens?
They flinch, tense up.
And if the muscles are tense, you can't feel anything. You've ruined your own exam. Being polite is about getting better data.
Okay, let's get to that exam. Palpation. Feeling the lumps. The notes mention this specific move called the bimanual technique.
This is a cool trick. You put a gloved finger inside the patient's mouth on the floor of the mouth, and your other hand on the outside of the neck.
So you're sandwiching the tissue.
Yes, you're feeling it from both sides, and this helps you answer a specific question. Is this lump the salivary gland itself, or is it a lymph node next to the gland?
How can you tell?
If you can feel the lump clearly between your fingers, like you can really grip it, it's probably the gland. If it's more slippery or you can feel the gland separately, it's a node.
That's brilliant. It's tactile triangulation. And then there's the fixity test. This one I found fascinating. You ask the patient to clench their teeth.
Right, or push their tongue against the roof of their mouth.
Why?
You're engaging the deep muscles. If a lump is cancer, it often invades and gets stuck to the muscle. So if you ask the patient to flex that muscle and the lump becomes immobile, frozen in place, that's a very bad sign. That's fixity.
And if it still moves around.
It means it's likely superficial. It hasn't invaded yet. You're using the patient's own body to test the depth of the disease.
So smart.
Huh.
Now, before we get to the final diagnosis, there was one red herring. Imran mentioned a cough, but said it only started yesterday.
Yes, the concept of signal versus noise. The lump has been there for 3 months. The fever for months. The cough started 24 hours ago.
So he probably just caught a cold on the way to the hospital.
Probably. A novice might jump on the cough and think, oh, it must be pulmonary TB. But the timeline doesn't fit. You have to ignore the acute noise and focus on the chronic signal.
Okay, so they've done the history, the plumbing check, the mirrors, the palpation. Time for the verdict. They ordered an ultrasound, a CT scan, and cytology. What did they find?
The ultrasound showed a heterogeneous solid lesion with necrosis.
Necrosis, dead tissue.
Yes, the center of the node is dying and liquefying. The CT scan showed the nodes were matted, clumping together. But the smoking gun? The thing that sealed it was the cytology.
Epithelioid histiocytes in a necrotic background. I'll practice saying that. Break it down for us.
It is the cellular fingerprint of tuberculosis. Histiocytes are immune cells. When they find TB bacteria, they transform into these epithelial cells and link arms to form a wall trying to trap the bacteria.
So the cells are the prison guards.
Exactly. And the necrotic background, that's the debris of the battle. We call it caseous necrosis, which literally means cheese-like. It is. The tissue turns into this soft, white, cheesy substance. But if you see that under a microscope, it's tuberculous lymphadenitis.
Which has that great historical name, right?
Scrofula. Sounds like a supervillain. For centuries, it was known as the king's evil because people believed a touch from the king could cure it.
So the diagnosis is TB. It fits the fever, the weight loss, the family history. Now this is where I get confused on the treatment. My instinct is, there's a bag of dead, infected tissue in my neck. Cut it out.
And that is exactly what you should not do.
Why not? Just get rid of it.
Because surgery only focuses on the lump, but TB is a systemic disease. The bacteria aren't just in that one node, they're probably circulating everywhere. Cutting out one node is like painting over a crack in the wall when the whole foundation is sinking.
And the notes mentioned a risk of sinus formation.
A total nightmare. If you cut into a TB node, the wound often won't heal. It forms a draining sinus funnel from the deep neck to the skin that just leaks pus for months. It's a mess.
Okay, so the scalpel is out. We use chemistry instead.
Heavy chemistry, anti-tuberculous treatment, or ATT. It's a 6-month marathon.
6 months. That is a serious commitment.
It's huge. And it's not just one pill. For the first 2 months, it's a cocktail of 4 different antibiotics. We just call it HRZE.
HRZE. It sounds like a bombing run.
It is, effectively. You're carpet bombing the bacteria. And for the next 4 months, you drop down to 2 drugs. But here's the insight from the sources that just blew my mind. The paradox.
Yes, paradoxical worsening. This feels so wrong.
Okay, imagine you are Imran. You start taking these powerful drugs, you expect to feel better, but 2 weeks in, the lump in your neck gets bigger. Maybe it turns red and angry.
I would panic. I'd stop the pills. I would think the doctor messed up, or the
Yeah.
bacteria is resistant, or it's cancer after all.
Exactly, and this is why it's a communication challenge. The doctor has to warn the patient about this.
So what does it get bigger?
Because your immune system is finally waking up, the TB bacteria had been suppressing it, now the drugs are killing the bacteria, that suppression lifts, and your immune system launches this massive inflammatory attack.
So the swelling isn't the disease winning, it's the cavalry finally arriving.
That's a perfect analogy. It's a specific syndrome. The war gets louder before it gets quiet.
That requires so much trust. You have to believe that feeling worse is actually part of getting better.
And if the doctor doesn't explain that up front, the patient quits the meds, and then you get drug-resistant superbugs.
So surgery is only for what? If it's about to burst.
Pretty much. If the node turns into what we call a cold abscess, a pocket of liquid pus, you might drain it with a needle just to relieve the pressure, but you never try to dissect the whole thing out. You let the drugs do the heavy lifting.
This just brings it all back to the start. We began with a lump, a simple swelling, but it was just the tip of the iceberg.
It really is. It just highlights the value of thinking in systems. To solve this, we had to navigate the lymphatic plumbing of the skull, check for silent cancers, analyze immune cells, and prescribe a 6-month chemical regimen, all from a swollen gland.
It makes you realize how connected everything is. We put things in boxes, dentists for teeth, dermatologists for skin, but the body doesn't care about our specialties. A problem in the lungs shows up in the neck.
The body is one continuous flowing system. You pull a thread over here, and the whole fabric moves somewhere else.
So here's a thought for you to carry into your day. Imran's neck lump was a map to a hidden infection. It makes me wonder, what other signals is your body sending right now that you might be dismissing as just local noise? Is that recurring headache just stress? Or is it something else? Is that fatigue just a lack of coffee? Or is it a metabolic flag?
Never settle for just treating the symptom. You always have to look for the source.
Thanks for diving deep with us. Stay curious, and we'll see you on the next case.